Hello, and welcome to today's webinar. I'm Shelley Gunther, Clinical Marketing Manager at Clarius. We've had a ton of requests for educational content for physical therapists, so we are very excited to be able to offer this one titled Ultrasound-Guided Dry Needling, Enhancing Precision and Outcomes. You're among just under 3,000 who registered for this popular session. Welcome, everyone. I think that's almost the record. We really enjoyed collaborating with Dr. Escaloni and Dr. Young and appreciate their willingness and enthusiasm in this venture. In a moment, they'll be joining us to share how they use their MAD ultrasound skills to enhance dry needling therapies. Now, a quick housekeeping note, please use the Q&A icon at the bottom of your screen at any time during today's session to ask questions, and we will address them in the live session close to the top of the hour and following the presentation. I have the privilege of hosting today's event, and I'll be introducing sonographer Janae Smith in a little while. Janae will give us a live demo after the presentation. Now, before we begin, I'd like to review a paper I came across when putting together the abstract for this webinar. A lot of good information in there. It was a double-blind randomized controlled trial that set out to compare the effect of ultrasound-guided dry needling with traditional dry needling in the treatment of pain and dysfunction for patients with knee osteoarthritis. They had three groups. I won't describe them now because I think the doctors are going to go into this a little bit more afterwards. But in general, their findings suggested that ultrasound-guided dry needling with exercise therapy may be more effective than traditional dry needling with exercise therapy or exercise therapy alone to reduce knee pain. And this provided evidence to support using ultrasound to guide your dry needling. Now, just a quick poll before I introduce our guests. What do you perceive as the benefits of using ultrasound in your practice? You can choose all that apply. Are you looking for better diagnostic accuracy or more accurate procedures? Or are you not using ultrasound at all? So we'll just give this a second to close off the poll. 3, 2, 1. And let's see what we get for our results here. Well, the first two, definitely accuracy of procedures and diagnostics. So I think you will find this really interesting, and you're going to see some great ultrasound techniques here. Great. So now I'd like to introduce Dr. Ian Young and Dr. James Escaloni. Dr. Escaloni serves as a physical therapist and movement specialist at Wellward Regenerative Medicine in Lexington, Kentucky. He is board certified, residency, and fellowship trained in orthopedics. And originally from Rochester, New York, he's a graduate of the University of Kentucky and Regis University programs in physical therapy. In addition to identifying the cause of pain in most complex patients, Dr. Escaloni teaches around the world on topics like differential diagnosis and manual therapies, and is a registered musculoskeletal sonographer. Dr. Ian Young is a physical therapist and founder and owner of Tybee Wellness and Osteopractic in Tybee Island, Georgia. He's a senior faculty with the American Academy of Manipulative Therapy and has been practicing full-time in orthopedics and sports for the last 27 years. Originally from Long Island, New York, Dr. Young earned an MSPT from North Georgia College and State University and is board certified in orthopedic and sports physical therapy. Dr. Young also holds a postgraduate Doctor of Science degree from Rocky Mountain University of Health Professions in Sports Physical Therapy. Dr. Young is also one of the few physical therapists who is a registered musculoskeletal sonographer. Welcome, gentlemen. I will hand the presentation over to you.
Thank you so much for that awesome introduction. And we're going to get started on this amazing presentation today. So for getting everything started, we need to define what we're talking about. We're talking about dry needling for all of the effects that it has and what it can be doing. So using this model that's demonstrated nicely by the Dunning article here, dry needling is going to be defined as the insertion of a thin monofilament needle as used in the practice of acupuncture without the use of injectate. It's going to be used for muscles, ligaments, tendons, subcutaneous fascia, scar tissue, peripheral nerves, neuromuscular bundles for the management of a variety of neuromusculoskeletal pain syndromes. So with that, that's a lot of different things that just the application of a needle can do. And so this is going to be having an effect just from the needle insertion to various tissues for modulation of a pro-inflammatory state, reorganization of collagen, reducing hypertonicity, restoration of sarcomere length, also stimulation of mesenchymal and neuronal stem cells. And this has already been shown to be very effective in a variety of different randomized controlled trials and affecting things such as mechanical neck pain, low back pain, headaches, knee osteoarthritis, shoulder pain, lateral epicondylitis, plantar fasciitis, and this is blinded and unblinded. And so this is what has already been shown to be helpful. Now we're going to be teaching you a little bit more about how this can be helpful further when you can see deeper to these tissues.
Okay, so does dry needling have an effect? I'm going to review some trials that James and I have been involved with over the last 10 to 12 years on dry needling, so we can sort of set the stage for, does it work, and what's the potential to use dry needling with ultrasound? The most recent trial that we completed was a randomized controlled trial on lateral elbow tendinopathy, published in 2024. And we looked at the addition of electrical dry needling and spinal manipulation to a traditional physical therapy program for subacute and chronic elbow tendinopathy. And what you can see in these graphs, I have it laid out kind of nice for you, that we have the dry needling group in blue and the multimodal physical therapy in red. And you can see, regardless of the outcome measure, whether it be pain, function, or disability, the addition of electrical dry needling seems to have a really nice effect in that 4-week to 3-month range. Another study on subacromial pain syndrome, where we utilized spinal manipulation of the lower cervical spine plus electrical dry needling versus a group that got traditional therapy, including glenohumeral joint mobilizations, SC, AC joint mobilizations, soft tissue mobilization. We found that just using dry needling or electrical dry needling alone with spinal manipulation seems to have a really nice effect again as we move into that 4-week and 3-month realm. Plantar fasciitis, which is a common thing that we see in the clinics, or at least in my clinic. Again, we add electrical dry needling to a conventional physical therapy program of mobilization, manipulation, and exercise. And we can see if we add that dry needling, things seem to get a little bit better as we move into that short-term and medium-term follow-up. Knee osteoarthritis, that's another big one that we see a lot in the clinic. And we can see that if we add dry needling here again, which is in red, we find that again, at 6 weeks and 3 months post initial treatment, things seem to get better if we add dry needling to our protocols. We move up to the jaw, same result. So things are pretty consistent as we move through the body and we add dry needling to a conventional program, or we do dry needling in this case, instead of intraocclusal splint therapy, NSAIDs, and mobilization. Here's another one that we looked at for cervicogenic headaches, and this is a really kind of interesting, especially for Dr. Escaloni and myself. We can see the addition of electrical dry needling and how it affects these headaches versus your standard mobilization and exercise. And for us, moving into the realm of ultrasound-guided dry needling in the axial spine is going to become a very big thing. And we're looking forward to that, to look at some of the pathology up there and really make some differences in these headaches. Some of our randomized control trials that are in progress now: medial elbow tendinopathy, Achilles tendinopathy, a knee dosage trial where we're using more needles and then following up at different time frames with more needling to see if it helps even further for long-term progress. Sacroiliac joint, tension type headache, and of course, a whiplash associated disorder, which we see a ton of. And again, we're not just tooting our own horn here, but the goal for this is to establish efficacy of dry needling and really set the stage for some new trials where we're going to come up with ultrasound-guided dry needling, and to really see how this affects it versus just your traditional electrical dry needling.
All right. Next phase of this is understanding a little bit what we're getting into. A big purpose of this talk is to talk about the tendon and tendinopathy and understanding how an effect can be happening with a needle. You have to understand the pathology as well as the histology behind these things we're dealing with the tendon pains. So when we're dealing with a normal tendon, it's going to have a normal collagen fiber alignment, just like my fingers were showing right there. It's going to have an inconspicuous ground substance. It's going to have spindle-shaped tenocytes, minimal vascularity and nerves into the major root of the tendon. However, an abnormal tendon is going to appear different, not only histologically, but also sonographically. So you can see it's got disorganized and altered collagen. It's a different type of collagen. It's going to be a type 3. There's abundant ground substance and activated cells that are hypercellular and increased blood vessels and nerves. And that's very important for the presence of pain. And if you look at the left versus right side of this model that was brought up, on the left side, it's very organized. Everything's nice, tightly packed bundles, which is what a healthy tendon is going to look like on ultrasound. But on the right side, you can see it's not the exact same. It's got a lot more disorganization. There's a lot of more proteoglycans that are involved with the deposition of this new tissue. And that's going to affect how the image looks because proteoglycans are very hydrophilic. It means there's got more water content and it's going to show up a lot darker. And so that would be the first hint that there may be something going on with that tendon when you're doing a sonographic scan to that tissue. So from here, this is giving an insight to why there is actually pain in the tendon. The image is just a guidance that there may be a problem there, and it's a nice supplement to your physical exam. But why is there pain there in the tendon in the first place? Well, it's because that the healing process is part of the reason there's pain. In order for a tendon to know that this needs to recover, the brain needs to send an extension of itself, a nerve, into that area to be kind of a foreman for a job site to be able to lay down new tissue. And so when that happens, it brings in neurovascular bundles into that area. That's essential for healing, but it's also why those things hurt. And if there's an interrupted process that stops that tendon from healing well, then that means there's going to be that neurovascular ingrowth into areas that are sustained longer than the healing cycle, making it have higher levels of pain likely to be there. So when you have a tendon that's injured, this is the process that occurs. You have a normal tendon, and then there's going to be some sort of reaction, whether it's some sort of acute trauma or some sort of decision. Like I decided to run a couch to 5K, but instead of doing something small, I just did the marathon right off the bat. Well, it's going to cause too much too soon, and the tendon's going to have a reactive tendinopathy in that state. In that process of trying to repair it, if it goes well, then it's going to be going from reactive tendinopathy on the left side of the screen to the blue arrow, and it's going to move back up to a normal tendon again. But however, if it was not given the opportunity to heal well, or something metabolically is causing it to not heal well, then it goes into the disrepair. And that's where it starts to be more of a degenerative tendon. And the majority of ones that we'll see in the office are usually in the age range of 40 to 60-ish, more or less. And that's going to be a reactive tendinopathy on top of a degenerative tendon. And those ones are going to have a specific look and feel, not only with physical exam, but also with the ultrasound exam. So here's just some good stuff to throw at you to give you some ideas for what you're getting into with this. So imaging in isolation may not be consistently useful for diagnosis, though specific findings on ultrasound may be predictive of future symptomatic tendons. Like if it's already hypersensitive with palpation, it's hypertrophied, you don't have a nice fibrillar alignment with that tendon, especially if there's a lot of neovascularity into that area or Doppler flow. If you put all of those together, that might be the problem that you're looking for. All right, next component. And the structural changes may be possible with specific loading and combined loading with nutrition protocols, though this may exceed typical timeframes given with rehabilitation, especially considering how we're getting less and less visits allowed in the classic outpatient physical therapy world. Exercise-based loading strategies alone may not always provide significant relief of symptoms. It's definitely something that should be utilized for a lot of people with tendon pains. But if you look at the majority of randomized controlled trials and clinical practice guidelines, it doesn't say cured, it says helped out. And what do you do about the cases that aren't helped out with the loading? You need another option. And so dry needling can have those effects on tendon pain and biomarkers viewed under ultrasound, as well as be considered when conventional rehabilitation has been unsuccessful. So what we're looking at from here are just some typical images you'd be able to see on an ultrasound probe of an abnormal tissue, tendons really. And on the top left-hand corner, that's a mid-substance of the Achilles tendon. It's engorged, so it's got a hypertrophied mid-substance, and it's a little bit darker, but it's still maintaining some collagen fibers. On the top right hand of the screen, you're looking at a supraspinatus tendon in long axis, and you're seeing there's an articular-sided tendinosis that's developing. Bottom left-hand corner, you're seeing a insertional patellar an origin patellar tendinosis that has a calcification as well. And you also are seeing short axis a combined proximal hamstring tendon that definitely has tendinosis in the bottom right-hand corner of the screen. All of these have been patients that have been symptomatic.
Okay, we're going to look at needling procedures for tendinopathy and tendinosis. So the reason I have this slide is here because I'd like to get the nomenclature and the literature straightened out, because we got to be careful about what we say and what we do. Physiotherapist, physical therapist versus the MD world. So ultrasound-guided dry needling, or ultrasound-guided needle fenestration, ultrasound-guided dry needling, and percutaneous ultrasound-guided dry needling are all in the realm of what you'd see in the literature for physiotherapy, and some MDs as well will use that terminology as well. So any of those things you can see, you'll see in the literature. As far as percutaneous ultrasound-guided needle tenotomy and percutaneous ultrasonic tenotomy, this is more in the realm, the physician realm. When you look at or you watch videos, or if you've ever seen a tenotomy, they use a very large, a large bored needle, and it has ultrasonic frequency. And as they go percutaneously, the ultrasonic frequency and the movement of that needle almost guts the tendon out. It takes that bad tissue that James was talking about and pulls it out. And so it starts a whole new healing process in getting some of that pathology out of there. Ultrasound-guided tendon fenestration back in 2013. This is the first time we really started looking at this. Jacobson et al. They found that elbow, proximal hamstring, glute med, patella tendon, and lateral elbow. Again, looks like there's good results that can happen with this with multiple case studies, but more to look into that, as we'll see in a minute. An overall narrative review in 2020 indicates that this, dry needling and fenestration is a standalone first-line treatment for tendinopathy. Ultrasound-guided for improved results, of course, and that's what James and I are seeing every day now. Fenestration, is it for physician or PT? It's for both. We both can fenestrate, whether they use a bored needle and we use a monofilament needle. The fenestration we do with dry needling is minimally invasive and a little bit lower cost. Now we're going to move right into the elbow. And what we're going to see first is just a very short 15-second video of dry needling, ultrasound-guided dry needling to the lateral elbow. And what we see here is we have the lateral epicondyle, and then running into the joint. So we're going to see that needle coming in, and this is the setup for the lateral elbow. And you can see I'm coming at a really shallow angle to try and hit the top portion of that lateral sloped epicondyle, because that's where we're going to see that common extensor tendon come in. And as I'm in there, you can see me now doing a little fenestration in there right at the emphasis of the tendon to try and create some initial healing for a tendon that has a long-term problem. We're trying to create a little more blood flow and some initial healing, because that tendon didn't heal after traditional physical therapy and medical attention. Again, this is the study that we talked about earlier, so I won't cover that again. If we look at lateral elbow in general over the course of the last 15 years or so, DN has done some good work. If we look at DN versus your medication and counterforce brace, we can see Dry needling and fenestration is over here on the left in our control group, which is your medication and counterforce brace. The fenestration and dry needling itself does really well over time, especially through 6 months versus control. And in this study, even we can see a nice change in the imaging, ultrasound imaging, prior to and after the needling, filling in of some hypoechoic areas and realignment of collagen on the post-DN. If we look at intralesional dry needling, platelet-rich plasma, and corticosteroid, if we wanted to compare all those three, very interesting study. DN here, PRP in the center, and corticosteroid injections on the right. We can see for pain and DASH, function and disability, we can see that all groups are about the same. Everybody seems to get better, whether you're doing dry needling, PRP, and corticosteroid injections. So that really says that, to me, I'm not saying that dry needling is the end all to be all, but all these things seem to work. It's about the patient and where the patient is at that time. Dry needling, if you're in the physiotherapy realm, is going to be a little bit more effective at the time when you're there. Corticosteroid injection versus dry needling and lateral condylitis. Again, there's a lot of studies out here on this supporting the fact that we really should be considering dry needling, and not just your corticosteroid injection, but we can see the differences between corticosteroid and dry needling in this study, and everything seems to be the same. Again, corticosteroids are effective, and so is dry needling, but we have to think about some of the consequences of corticosteroid injection overall. Again, we're looking at another study here where we're looking at dry needling again versus corticosteroid injection. And in this study, we're seeing that your dry needling really has a nice effect at 3 weeks, evens out, and about the same as corticosteroid injections at 6 months. But at this study, a little bit quicker relief with the dry needling. So we really have to look at all these studies and sort of make an educated decision here. Ultrasound-guided platelet-rich plasma versus dry needling, a busy slide here, but overall, I'm going to give you the take on it, is that everything seems to be the same, whether you do dry needling or PRP. I think, honestly, almost equivocal, except for the end stage consequence of the tear healing. We see at 6-month follow-up, PRP does a little bit better from a regenerative process. So if that's what we're looking for, then PRP is the answer. But when we look at a 3-month follow-up, everything seems to be about the same. So that's good news. PRP is a little bit more expensive. Dry needling is a little bit cheaper, and you can get to your physio or physical therapist to do that. This is a really nice study. This supports dry needling, ultrasound-guided dry needling instead of the open release surgery, or should I say, it's about equal. So instead of releasing the ECRB, we could also do ultrasound-guided dry needling, as James and I talked about, creating a new healing environment. And you can see these two graphs here. One is the patient-rated tennis elbow evaluation, and the other is the quick dash. And you can see the fenestration is in blue and the surgery is in red. And on both graphs here, everything seems to stay about the same, except for the quick dash at 6 weeks and 3 months. As we move into 6 months and 12 months, really no difference. So if we can really use ultrasound-guided needling to avoid surgery, I think it's a good thing.
This means it's my turn again. All right, so we're seeing my awesome assistant right here volunteer to be stabbed again, and I appreciate her for that. And so we're looking at a supraspinatus. And so what you're going to be seeing on the screen, we're looking at the greater tuberosity insertion point for the dry needling right here. We're having this in long axis, and the injection, or at least the needle placement, is in plane. So if you have one of these things right here in plane, it's coming in this direction, so you can see the whole needle. It's a very easy technique. And if you're going to try to mimic something like this at home, this is called the modified crafts position and side lying. And you see I've expertly placed a pillow underneath their elbow. So that way, if you were trying to do this, you don't have their arms squeezed up and tight like that. They're more relaxed because everybody likes pillows. That makes this a whole lot easier for all of us. So let's dive into some of the literature behind this. So the first time this actually showed up that I dove into was back in 2013, which is something you got to think about. Right now it's 2024, and some smart people were already figuring this out more than 10 years ago. So it just shows how behind at least how behind I feel. With this, you're seeing that this person had supraspinatus tendinopathy, and this was treated with dry needling. And they put in baseline 6 of 10 pain. 10 days later, 0 out of 10 pain. And the cool thing about this, even with the technology that they had back then, they were able to trace that there was considerable healing in that little bit of a time frame, showing that these tissues were starting to pull together. Pretty cool. All right. So next study. So this is one from that same year where they're looking at PRP compared to dry needling. And so for this one, it was ultrasound-guided dry needling in a single session. So instead of a single one moving into there, they did fenestration, tapping about 30 to 40 times. And they compared that with PRP, 2 sessions for that. And so for the sonographic improvement for the tear and the tendinosis, you could tell at 6 months, there's a 14% improvement overall in the tear and the tendinosis, just from the visual standpoint, compared to a 7%. So that's not bad. Just having a needle in there with nothing in it still did some good effect. Now you can see on here, there's also the spotty and the visual analog scale. Also, both of these improved over time, and these were people who did not do well with traditional physical therapy beforehand, but when they were recruited. All right, so this one's an overall narrative review to see, is this type of procedure, any sort of shoulder pathology, can needle-based therapies be tolerated? Are they safe? That was a question they asked. And they posted a pretty good argument, which this is the nice summary of it, that musculoskeletal interventional procedures are tolerated well, safe, effective, and should be considered as the first-line approach for minimally invasive procedure in several pathological conditions of the shoulder.
Okay, so we're going to move into the hip, just a little bit on the hip. We're going to cover the glutes and greater trochanteric hip syndrome. And right here we can see just a short video of the setup of how we would look at the glute med in long axis. And we'd be looking at the greater trochanter here with the glute med coming up and over, and we'd be looking for the needle to come in here at a 45 or even less of an angle to address any tendinopathic changes. Dry needling versus corticosteroid injection in the treatment of trochanteric pain syndrome. Randomized trial, again, visual analog scale and a functional scale on the right. We have dry needling in blue, cortisone injection as in orange, and we can see through time, baseline 3 weeks and 6 weeks, things seem to improve in both groups. So it's very similar to the lateral elbow. We can see that dry needling does have a really nice effect, and it should be considered as a first-line treatment. Again, another greater trochanteric pain syndrome, percutaneous tendon fenestration. So we're using percutaneous fenestration instead of dry needling in this, or at least the nomenclature, versus plasma injection for gluteal tendinosis. And we can see that PRP is on the left, DN is on the right, and we can see baseline 8 days and 16 days post, and we can see both groups are about equal if we look at the numbers. And then percent of patients that improved, 79% in the PRP and 71% in the DN and fenestration group. So, I mean, no significant differences there. So again, repeat offender, we can use both of these. And I think that it just depends on the patient and where they are, but we need to consider dry needling for sure, especially ultrasound guided. We'll move into, I'll do a video on the patellar tendon here, right before James does the quad tendon. And you can see here that we're seeing the needle come in here, right at the inferior pole of the patella tendon. And what we're going to do is the same thing we did as James did in the shoulder and I did in the lateral elbow. We're going to find that pathologic tendon. We're going to move in and fenestrate, possibly wind, and create a nice healing environment.
All right, in this close-up of my face, you get to see the quadriceps tendon being needled. And so as you're appreciating this angle, I'm once again going in plane long axis to the quadricep tendon, aiming for the insertion of the patella tendon on the patella. And you're able to see that angle of the needle as it's moving in. I'm giving a little wiggle in there just for your viewing pleasure and her displeasure, so that you guys can see what's going on in there. And I appreciate my model Ashley again for doing all that. So this is something that is very helpful for a lot of different conditions that we see a lot in the office, do this all the time. And there's also some good literature that gives us some guidance on when to do this. Let's check it out. So this was a trial that looked at platelet-rich plasma as a treatment for patellar tendinopathy. So a big thing that I want to emphasize this study, it recruited people who had already failed 6 weeks of physical therapy doing loading exercises. And for patellar tendinopathy, eccentric loading is one of those big things that you should be doing. And these guys did not do well with that. So they recruited into a secondary arm of this to try to see if they just did something to get them over the hump. Would that help out a little bit more? So what they did was they had 10 times of dry needling into the tendon where the pathological lesion was identified, and then compared that to PRP. And they had a 5-phase eccentric training program with cardio, flexibility, and sport-specific rehab. And as you can tell from this, the visual analog scale and the Leishholm index both improved at a pretty comparable level. So which one is it? Which one's better? Well, I don't know if it came down to if you just had a needle in your hand and a patient just needed to get better, that might be an option to use that dry needling technique for you physios out there. All right, so ultrasound-guided needle fenestration be considered as a treatment option for recalcitrant patellar tendinopathy, a retrospective case study, right, 47 cases. So when we're looking at this, it's the same type of thing. Recalcitrant, meaning that they failed the eccentric loading, just like we were talking about earlier. So when we look at the outcomes from here, 49% had an excellent outcome from this. 30% had good, 4% fair, and 7%, 15% poor. So if we're looking at the total of the data, if we're trying to get somebody to get them over the hump, just because the PT exercises, the eccentric loading wasn't working, doesn't mean now there's nothing. Doesn't mean, okay, I guess we got to go jumping from here to surgery. No, there's another option that can be done. And looking at this is a big percentage of that population that you can definitely help out just from the addition of some needling. Here's another one looking at the efficacy of ultrasound-guided dry needling as an adjunct to conventional physical therapy. And so with these, you can see that at the 4-week, there was changes in the ultrasound, not only in the tendon thickness and the hypoechoic region and Doppler, but looking at this visual analog scale also was improving much better than the exercises alone had been for these people. Good study. All right, this is the one that Ian turned me on to. We talked a little bit about it earlier, but Ian, you have a nice spiel of this one.
Yeah, yeah. So Shelley mentioned this one earlier, and she did a great job lining us up with it. And she gave you the specs on it. But really, what it comes down to on this is patient buy-in, because what happens is that when you have the patient on the mat and they're watching the needle go in versus the same procedure where the ultrasound is turned away and they're unable to see the needle go in, the difference between those two is unbelievable. And you can see that in the graphs and how Shelley explained it earlier. So it's really an amazing buy-in there. It's not only an amazing physiological effect, but having the patient there and just realizing that things are going to get better if they see that needle is really big. Another big component of this study is the number of structures that they visualize and used ultrasound guided needling on. And you guys can look at that a little bit later, but I really recommend running through that and taking a look at that randomized control trial. It's going to help your practice to a whole different level.
Good find.
So if we look at ultrasound-guided interventions for tendinopathy, and we think about clinician and patient decisions, because we have to make those sometimes together with the patient now that they're sitting right in front of you, I think we can, from the results that James and I gave you, we can say CSI really has somewhat better immediate results, especially if they're flooding that tendon and there's any inflammation around that. They're going to have an immediate result, and probably pretty more of a reduced cost at that time versus dry needling if we have to go twice a week for 6 weeks or 4 weeks or whatever it is. But CSI has a short-lasting effect, and not in every study, but in most studies, around 6 weeks, we see it tailing off, depending on the pathology and the area of the body. And the reoccurrence rate is on the higher side after that. So these things we have to think about. We consider CSI option for an acute injury. If we think about professional athletes or high-level college athletes or even high-level high school athletes, we have to consider corticosteroid injection at that point. But we really need, and we're really looking at the acute effects of dry needling, especially ultrasound-guided needling coming up, because I think really if the studies are done accurately and we get the right randomized controlled trials, we're going to see acute changes with dry needling. PRP versus CSI, James and I already covered that. I think it depends where you are. If you're in the clinic with your physio and he's got the needle there or she's got the needle there and you have the ultrasound machine there, you're going to wait to go to the doctor or get your PRP in 2 or 3 or 4 weeks, and it's pretty costly. Or are we just going to get the ball rolling right there? Lastly, ultrasound-guided needling basically has equivocal results to CSI and PRP overall, especially within that 6-month time frame.
So when it comes to the ultrasound-guided dry needling, I used this 7 times today. I just finished seeing patients. I'm literally in my office still right now. So what does it come to? Patient buy-in? Yes, there's a huge patient buy-in. When I pull out my phone, I'm like, here, hold this. You're going to now tell me, as we look at this thing right here, is that the spot right there? Yeah, okay, I'm gonna poke it. Tell me what you say. All right, that looks like it hurts. All right, cool. Does it hurt? Yeah. Okay. Then all of a sudden they know you found the spot. There's the buy-in that's great with it. And so you're going to be more efficient with that. Instead of having all these areas and you're playing whack-a-mole sometimes with your treatment, you know exactly where that spot is. It makes it a heck of a lot easier. And you're going to have just better specificity behind it. You already see that from the studies that we pulled up. So by having the appropriate placement for that needle, you're going to make it so that the tissue around it can start to heal a little bit better and work well. Not just this, everything else is kind of working independent of this just lesion that's just kind of inert, not helping out. And you're also going to have a better outcome assessment because the patient will be feeling better. You hit the spot. It doesn't have a reason to hurt. And those outcome measures have to improve from there. All right, so good stuff to add.
Yeah, I'll add to that slide, James, if you don't mind.
Of course.
From a cash practice perspective, your ultrasound guided dry needling is really imperative, especially with your portable units. We're charging a lot for an hour of our time, and the patient, there's expectations, especially when you're only seeing 1 or 2 or 3 or 4 a day. And when they're coming in and it's just you and them, and the cash is on the table and they can see their problem and they're seeing what you do to it, it's almost, you almost have to have it in that case. I just really wanted to bring that up as far as cash practice goes.
Yeah, every place is going to have this in their office in the next 10 years, guaranteed.
Yeah. Directions for future research. This is just a small list of what I would love to do, or we would love to do. As you guys know, research takes a lot of work and a lot of pain, but we're going to get there, especially with this ultrasound guided stuff. Ultrasound guided dry needling on hip and shoulder and ankle. We need more on that. We need to include ultrasound-guided dry needling and very appropriate tendon loading strategies to find out, okay, what happens if we load and strengthen that person over the correct amount of time and follow up at 3 months and 6 months. I'd love to see those changes. Objective ultrasound tissue changes versus histology. We need to start seeing these ultrasound images and getting blood work done and histological to assess histological changes so we can find out what is actually happening when those images change. And we also, again, same thing, we have to do patient-reported outcomes and correlate with those ultrasound changes, and I think that'll change reimbursement in the bigger clinics that take insurance. Also, James and I are big on this. We're always looking for the answer to the changes in ligament, articular cartilage, fibrocartilage, and the histological changes when we do ultrasound-guided dry needling and follow up with these images. Are these structures, are these tissues viable, and what happens? Corticosteroid versus ultrasound-guided electric dry needling and acute tendinitis. I'd like to see that study. That'd be very cool to find out if we can match corticosteroid outcomes. Ultrasound-guided dry needling, the cervical and lumbar spine. James and I are extremely excited about that. There's not many courses on that, and we have an upcoming course on that we're hoping everybody can come. Ultrasound-guided peripheral nerve stimulation. There's some evidence coming out now that in chronic musculoskeletal pain, this is a thing. And we can see that nerve and we can see changes in that nerve. And if we stimulate that nerve under ultrasound guidance, I think there is big time potential there. And then again, educating as many clinicians as possible in dry needling, ultrasound-guided dry needling, and MSK ultrasound. That's James and our life right now. And we want to get as many RMSKs out there as possible so we can really divvy up the research and get some good data.
All right. So with this great study, this is just an example of what we're looking for in the future. So this was a really cool study that looked at some people who had recalcitrant lateral elbow tendinopathy. We've already discussed how just by putting a needle in there really has some profound effects. What this study did was they traced it not only just kind of short time periods, but they traced out things like pain and function and how does it look under sonography. And then when you see pre-procedural, 3 months post-procedural, 6 months post-procedural, then 3 years post-procedural, and it wasn't a short-term change and it's not all in their head. There's actually a change in their pain, there's a change in their function, and this is traced also with how the tissue is looking as a result of this type of intervention from people who had already failed the standard interventions. We love this study because it showed this is the model that we'd like to keep for some other ones.
Yeah, I'll make a comment about this. This is a really nice slide to look at because the images, and this is 2015, and ultrasound wasn't that great then, right? But look at the images here, and you can see the changes in vascularity. And at 3 months post and 6 months post, you can see the ultrasound images changing and the collagen alignment and the reduction in echogenicity. And it's just, it's unreal. And I think that's where we need to be.
Mm-hmm.
And if we take all these studies that we've done and all the ones that we're going to do, and we end up with outcomes like this, and they match up with our patient-reported outcomes, I think things are going to get really good in the clinic and for reimbursement, honestly.
So it was a little bit of a shout out in case anybody wants to know about just complex cases and how you can look at stuff with ultrasound, and especially in cases that have surprised me. These are ones that have come into my office that didn't do well with physical therapy elsewhere. Then I did a sonography examination, and the results surprised me. And it's totally free. You can find me at the Ultrasound PT. And it's just cases where I describe somebody came in, they hurt their shoulder, they did PT for this much, it didn't work, they got referred to me. I looked at it and I said, whoa, that's not what I thought. And that totally changed what I was going to be doing with that patient. So again, nice and free. You guys can find it all over the place. All right, and we've got a couple classes coming up, and the ultrasound-guided dry needling and in musculoskeletal ultrasound for our certification. I got to be in, I'm teaching this next one in Jersey, and I think he's got the next one down in Dallas. So we do those separately. This is where we're doing our certification, so you can actually work towards having your RMSK, and those are the different locations we have it. Me and Ian teach together, and we're a fun, comical team.
And that's a wrap, I believe.
Mm-hmm.
Excellent, excellent. Thank you. I am just going to hand things over to Janae. She's just do a quick demo with the L15 scanner, which is the one you guys used in your for your dry needling.
Thanks, Shelley. For my demo today, I'm going to start at the lateral elbow. So I'm going to head on to the patient demographic page here. And from here, we can enter the patient information, birth date, what body part we'll be looking at, and then we can select the elbow preset from there. And I'm going to start sagittally to the radius here. And I've got my patient's elbow bent 90 degrees and just raised up on his hip a little bit, 75 to 90 degrees raise of the wrist. And coming into plane here, we can see the radial humeral joint and also the lateral epicondyle. And this is where the common extensor tendon will originate on the screen here. So we're looking for nice parallel fibers, even echogenicity of that tendon. And if we find an area where we are seeing a more hypoechoic appearance to the tendon, we can heel toe the probe. So that just means rocking the probe, and it'll change the echogenicity of the tendon, and we can rule out a pathology versus a artifact, the anisotropy artifact.
Definitely, and an interesting note there. If you take the slope of the lateral epicondyle and cut it in half, that top half of the slope is going to be the common extensor tendon, and the bottom half is going to be the radial collateral ligament.
Yeah, that's good. And another nice feature of the system is the voice control. So we can turn the voice control on by selecting the measurement icon here at the bottom of the screen on the bottom left. And what that's going to do is allow us to change the parameters of the image without touching the screen. So we can freeze the image, capture image. And that's really helpful with procedures like dry needling where both of your hands might be busy. And also you can increase the depth. So there's quite a few things that you can adjust there on the image. Hands-free,
I'm a
it's
huge
really
fan of the needle mode on that one. Helps me when I'm trying to put a needle in, and I've got my hand on one hand, I've got the phone, the other hand I've got the probe, and I'm sorry, one hand's got the probe, the other hand's got the needle, and then I've got to figure out a way. I can't see that very well. I don't want to just kind of put everything down, rearrange some stuff, clean my hands again. Just like, oh, nope, I can just say needle mode, increase depth, increase gain. All right, freeze. All right, stab away.
Yeah, super helpful in a procedure like dry needling.
Mm-hmm.
So from here, we will head over to the knee, and I'll select the knee preset and move down to the patellar tendon. So I've got, I'm going to start inferior to the patella. And coming into view here, we have a nice view of the patellar tendon, and we can assess it all the way down to the tibia here. So again, we're looking for those nice, even parallel fibers of the tendon. And if we want to accentuate that tendon even more, we could turn on the AI feature. And what that does is it highlights the tendon for us. And you can see you can change the opacity of the highlight, that orange overlay. You can also, when we freeze the image, it takes a measurement of the thickest portion of the tendon, and it displays that measurement on the top left portion of the screen, and it also labels the tendon for you. So
That's almost
really
not
helpful.
fair for all the years I studied. It's just right
It's
there.
so
It's so
true.
cool.
No kidding.
So really helpful for beginners.
Oh, yeah.
Excellent. Great.
There we go.
Thank you, Janae. That's
Thanks,
awesome.
Shelley.
Yeah, as a former colleague used to say, the ultrasound gives us superpowers. And so, James, like you were saying, you know, when you don't know what you don't know, and what's under the skin might surprise you, right?
My dad used to tell me that a lot as a teenager.
Yeah. Excellent. All right. Now, before we open the floor to questions, and we have a lot of them, so we may run over a bit. Please bear with us. I'll try to get this to as many as we can. But I'd like to help everyone continue their journey into bringing handheld ultrasound guidance to their practice. So please complete this poll and let us know how we can provide further information. Do click on as many options as apply to you. And while you complete the live poll, I'll take a minute to introduce you to the affordable Clarius HD3, our third generation line of portable ultrasound scanners. Now, together with artificial intelligence, Clarius scanners deliver image quality only found on larger ultrasound systems, but at a fraction of the cost. You're looking at about an 85% savings. And with AI replacing complex buttons and knobs, it's as easy to use as your smartphone. So you can quickly diagnose MSK injuries, guide management, and also for safe ultrasound-guided procedures like PRP injections, and as well dry needling like you saw today. Clarius is also wireless, freeing up space with zero footprint for ultra portability in a variety of settings. You get free movement with no wires to get in the way, which also makes Clarius so much faster to clean and disinfect. And only Clarius delivers linear wireless scanners with an ecosystem that includes a free app for your iOS and Android devices for unlimited users. Available with our membership, Clarius Cloud is used to easily capture and manage unlimited exams from anywhere. It's a great tool for saving images, and especially if you're following a patient with serial studies. Your membership also includes in-app Clarius classroom videos and onboarding with a Clarius clinician to build your skills. And Clarius Live delivers one-click telemedicine if you like to share live scanning with a colleague for a second opinion. And with your membership, you also get our advanced MSK package that includes dedicated presets, as Janae demonstrated, and features like the MSK AI that you just saw. Now we have a special offer for webinar attendees today. It's an MSK bundle, we're calling it, and it includes the L15, which you saw today, and the C3, suitable for hips and spines and deeper MSK structures. Also included is a 3-year membership, which gives you access to all the latest AI and 3 years of Clarius Care. You can scan the QR code here to take advantage of this offer before July 19th. Now we'll close off the poll, and thank you very much. If you ask for more information, we'll get back to you in the coming week. And now I'd like to welcome back James and Ian to answer your questions. So again, you can use the Q&A icon at the bottom of the screen here. Wow, we have a ton of questions here, gentlemen. I'll start, and as I mentioned, if we don't get to your questions, we'll follow up with answers. So we'll get back to you. Now let's see here. The first one, as a clinician, do you find a big difference between conventional dry needling by palpation and ultrasound-guided dry needling, effect-wise, and patient satisfaction, etc.?
So is there a difference between the palpation-based? Yeah. Because I've just done that enough times that you'll hit the spots and you'll find the patient. I've always told this to patients that the area that we're working on seems to get smaller and smaller and smaller, but there'll be just like a couple pinpoint areas, and that's when their progress starts to go a little bit more in that plateau area. And when they're still saying like, there's a spot here, there's a spot right from there, you're poking around, you're hoping to find it, but sometimes you don't. And in that same process, they're having greater degrees of pain, maybe a little less trust. This is going to get them over the hump all the way, especially if there was, like, for example, a surgeon who wouldn't, and this would never happen, would say, looks like you've got degenerative disc disease, you need surgery, something like that. And so they already have that planted in their head. But if you can find that spot with the ultrasound and you tap it right on that exact spot, then you're not playing the whack-a-mole anymore. It's exactly there. And their symptoms actually do start to continue to move up and up and up in a positive manner.
Yeah, I'll add to that just for a second. There's a lot of times when these patients with chronic tendinopathies come in, they've been examined by somebody, whether it be primary or orthopedic, and they come in and they have a certain area that they've been told is the problem. And just as James said, that's just not always the case. And they come in and they point to it, and then you do the ultrasound and you find really what's going on based on our physical exam and the ultrasound. And they go, well, what are you treating that for? Well, that reproduced your pain. That's probably the issue. And all of a sudden they realize that, wow, that really was the issue, and things start to get better.
Okay. There are a couple of questions around kind of cleanliness, sterile technique. This one, when dry needling with ultrasound, is there a fear of infection risk with the gel touching the needle, or how do you mitigate that situation?
Yeah, you want to have the sterile gel as you're using it. You would prepare the surface like you would for any sort of clean technique ahead of time. And if you use a traditional gel, that could be a problem because it can be a harboring agent for a lot of different bacteria. And so you just get around that by just getting the sterile gels.
What size of needle do you use? And do you use sterile gel? So the sterile gel we know, but yeah, size of needle.
Okay. So a lot of the times if we're using like Serum brands, they've got ones that are 0.30 by 40 millimeters. Those seem to be the ones that Not only are they thick enough so they go where they're supposed to go, but you can also trace them a little bit better when you're having the sound wave bounce off of the needle. Myotech also has a couple ones that are a little bit thicker than that show up pretty well. And so those are a couple ones that I've played with that show up pretty nicely. The really long, extra thin ones are really hard to see. And when you do see them, one of the things that I've been impressed with was that how well those needles don't go where you think they're going. They wander, which is definitely a problem if you're working around that thoracic spine. And so, but I didn't realize that until I was able to monitor where those needles were going.
Yeah, I agree with James. The thicker the needle, the better, because it's just less problems when you're trying to get in there.
Are there any studies on ultrasound-guided dry needling for patients with CMCOA de Quervain syndrome, tenosynovitis?
Yeah, we just had one, the Spinal Manipulation Institute put out one that was a case study, but it was just on non-ultrasound guided. But I can definitely tell you right now, it'd be very easily replicated using just ultrasound for a similar, if not, I think potentially better result. Because I do that in the office all the time. I've been doing manual therapy for a long time. My thumbs are jacked up, plus I'm a wrestling coach and I do Brazilian Jiu-Jitsu. I don't even know how these things work, and the only way I'm able to keep it up is by saying, okay, where's this thing? Okay, oh, okay. And I'll put the needle on the spot that doesn't hurt and it doesn't look funny. That makes sense. I put it on the spot that hurts. I look at it, I'm like, oh, that's why, because I jacked it up. It's going to be something that's coming out fairly soon. And I expect in the next couple of years, there's going to be at least a case study out with that because it's so easily done.
Yeah, the visualization on the CMC joint, especially that first one, and just the wrist in general is amazing with the ultrasound units. So it's going to be really it's just it's going to be a really good study when it's done to see those needles go in there.
All right. Is it necessary to penetrate the tendon with the needle to achieve therapeutic effects? And generally, how long are the needles left at the treatment site?
Well, there's a variety of studies that are out there that are just showing from the non-guided ones where they just kind of tap around it versus the ones that are fenestrating. And so if there is a reactive tendon, just the action of just placing a needle onto that component of it can calm things down without causing a whole lot of problems with the tendon. However, if there's more of a problem where the central tendon seems to have a problem, especially at the enthesis, those are going to be a little bit more difficult to treat, not only with just tapping with the tendon or even exercise because of the stress shielding component. And so you can get around that further with just the needle entry into that spot where the greatest degree of pathology is. And based off the literature that's given us guidance already, for the people who have the recalcitrant problems, there's more likely to be more of those problems I just described. And in that case, having some guidance towards the pathology seems to be the ones that you're going to need to be able to do or need to do for those more complicated patients.
Yeah, and in the studies that we do, we tend to fenestrate or pepper the enthesis in some of those studies that I talked about that we did. And then we actually do leave the needles in with electrical stim for at least 15 to 20 minutes.
And just kind of on the heels of that, there was a question said, does the penetration into the tendons cause damage and can it cause worse healing results? Are there any precautions after a session?
Yeah,
Good question.
you stuck a needle into a tendon. Yeah, there's damage. You poked a hole in it. But from a standpoint of what is the literature that's out there that's shown, if you're just putting a single needle into a tendon and you're not like going crazy with it, within about 10 days, it'll start to tighten up a little bit further and it won't cause worsening tissue damage. There's good studies on that. Now, however, if you're fenestrating quite a bit, then it can take a little bit longer, but within a 6-week period, those studies have shown that not only has the tendon healed, but it has healed beyond the original standpoint, at least in those models that they've done. And for precautions afterwards, if you're just putting a needle in and out, well, that's not too much of a problem that I'm too concerned with. However, if there's fenestration, at the very least, I'd say with 7 days before you do anything that's pretty substantial. And in some cases, they've waited even longer for that. But for
Right.
most of the patients that I have, I'll tell them if I've just needled this area of the tendon and I know that you're going to be doing some sort of loaded tendon activity, not just loaded, but compressed loaded, then that means I'm going to have to like hold you back from doing some stuff. And they can do something like open chain pump work with a light band for a set of 100 instead, and they'll still at least be able to get some stuff moving forward from muscle conditioning in the meantime.
Yeah, and to add to that, just because James and I are doing this every day, uh, we we always think about that inflammatory phase and moving into the next phase. So if we're really going at a tendon that has failed multiple clinicians and multiple, interventions, then yeah, if we're going to go hard, we're going to say, okay, we need you to get back in here between 7 and 10 days. Right. So, you got to think about healing time and all those things. There's a lot involved, I guess. That's what I'm trying to say.
Right.
Not
just sticking a needle in there.
Yeah, it's not that easy, unfortunately.
There was a question about patient body habitus in somebody that's larger. Does that influence the ability to perform the dry needling effectively, and what's the patient tolerance?
No, it's going to impact several factors. When you've got a lot of adiposity around a tissue, that's going to be superficial to what you're viewing, and it's just going to brighten up everything. And so you're going to have to understand your knobology to be able to see things a little bit better. Just fiddling with the gain and the dynamic range, it seems to help that out. And additionally, to be able to access that, if there's just a lot of soft tissue in front of that, sometimes you have to take this thing and compress it down a bunch so you can at least see where that tendon is, and then maintain that for the intervention to be occurring successfully. Now, the challenge will be if we're trying to replicate one of those studies, if you guys are, you can't just put the needle in after you squished it and then let go and then hopes everything will work. You've got to wind that so the tissue is maintained. There's going to be a grasp to the needle at that depth. And then there's going to be a little bit of an ongoing stretch as the residual soft tissue pushes up, which is actually a nice therapeutic component if there's been compressed tissue at the other superficial levels as you've been treating as well. So that's one thing that you can take a look at. Anything you'd add to that, Ian?
No.
All right. Does dry needling fenestration cause internal bleeding, leading to increased platelets of availability to heal, similar to PRP treatment?
Yep. Poor man's PRP is what we call it in our
Yeah.
office.
Okay.
Yeah. So
Yes.
that's one of the mechanisms behind healing behind it. If you look at any background studies on why does something like an orthobiologic like PRP work, that'll give you further guidance for the different various growth factors that are associated with that, from the I think TGF beta 1, VEGF, and the variously interleukin factors.
Mhm.
Those are going to be having an effect on why is it that tissue is healing at that site from where the tissue damage was occurring. And as the platelets are brought into there, it is going to help out with the healing. But it's a little bit different from a PRP because the platelets themselves, after the platelets are brought into there, they essentially autolyse. And then from the fibrin clots, those are the signaling pathways for the growth factors. And when you're just doing it with a needle as opposed to the platelet-rich plasma or platelet-poor plasma, how you're doing it, it can potentially have a longer congregation of those platelets afterwards, and that can be a little bit painful for the people if you're doing a ton of it, which is another reason why we tell them to just chill out for about 7 days afterwards at least.
Yeah, and then there is some literature out there, and James and I have scanned that pretty well, especially we talked about one this morning actually, Achilles tendinopathy. Um, there are some studies to show when you dry needle a tendinopathy, and there's histology associated with these studies to show pretty much everything James just said. So there's stuff out on Achilles tendon in humans, and there's a bunch of stuff on supraspinatus tendons in rats and some other things, but these things are all real important, and that was a really good question.
All right. Now, there's quite a few questions about your courses, so I think I will just leave those for now, and perhaps you can address those.
They're awesome and the most amazing that existed.
Easy
Sign up
peasy.
today.
There's a lot of people asking about your courses in Europe. Any chance you'll be heading there?
Well, send them It's a possibility.
We can make these things happen. We can make these things happen.
You never know, right? Never say never.
We have done a lot of courses in the past over in Italy and
A
Greece.
few over in Italy and Greece, yeah.
But COVID took a hold of that, and we're looking to get back into it for sure.
Yeah,
Right.
we've definitely done it before.
All right, well, we are approaching 10 minutes over our allotted time here. So I think with that, I will call it. Thank you for all of your questions, everyone. And many asked for more information. In our Clarius website in the education tab, you'll find lots of information, on-demand webinars, and Clarius classroom videos, including the videos that you saw in the presentation today. And we encourage you to sign up for training with AAMT. And a reminder that you will all receive a PDF copy of the slides and a webinar recording in an email in the coming days. So thank you so much, Ian and James, for sharing your best practices, and a very big thank you for joining us. Thank you, Janae, for an amazing scanning session. And until then, keep scanning, and we hope you have a wonderful rest of your day. Thank you and goodbye.